everybody, back to another Australian neonatal lectures and webinars. And today it is my great pleasure to introduce Dr. Coen Butters. He's a pediatric infectious disease specialist and a general pediatrician here at our hospital, the John Hampton Children's Hospital. Clinical researcher, specific interest in immunocompromised children and infections, but also a hard sort of promoter of improving antimicrobial stewardships and learning healthcare systems. But today he's going to talk to us about the newest thoughts and understanding about congenital CMV infections. So Coen, over to you.
Thank you. Thanks so much for having me. And it's lovely to talk to a group of neonatologists. Thank you to the people across Australia that have got ID physicians through their paediatric training, because I'm not sure ID physicians make great neonatologists. And I think we tend to shy away from procedure and sick babies, but we like to be at the end of the bed. So thank you to everyone, particularly in Victoria, who supported me through my training. It's a great honour to talk about CMV infections in 2026. And I think this evidence base has been slow moving over time, but I think it's a really pertinent time to talk about CMV because there actually is some further evidence about how we can approach treatment. Before I begin, though, I just wanted to acknowledge that I'm here on a Awabakal land and to acknowledge traditional custodians of the land where we meet today, pay my respect to elders past, present, and extend that respect to any Aboriginal or Torres Strait Islander people joining us today. So we'll talk about transmission, and I'm really going to cover from the basics of CMV, pathophysiology, right through to diagnostics, some newer information around prognostication, which I think there's an important role of working closely with the neonatal team around talking about long-term developmental outcome, specifically getting into the nitty and gritty of treatment as well as some emerging therapies. And then I really want to touch on the controversial aspects of prevention. So there's a group of obstetricians, as you may be aware, that are very passionate about serology for all women and early treatment of CMV, primary CMV infection to prevent transmission to the fetus. And then there's the bigger question about the role that universal screening of infants might play, how our health services and systems and policy and funding might support that, and what that might look in the places where you work. So hopefully we've got some time at the end to discuss some of those aspects. So it wouldn't be an ID talk without starting with the bug. And so here's our virus, this cytomegalovirus. And David Kimberlin, who I'll present a number of papers from today, is really one of the leading researchers in this area, and he describes it as an omnipresent human-specific DNA virus, which is sort of terrifying. This is the largest known human herpes virus, and it's a double-stranded DNA virus, so it's a relatively complicated virus. It often gets forgotten that it's part of the herpes viridae family, so its cousins are HSV, varicella, EBV, and HHV6, all of which can cause severe disease in neonates and infants. So it's actually herpes viridae 5 or HHV5 disease. The fascinating thing about CMV is that once infected, we carry this persistent state of infection, a bit like HSV, so it actually remains within the human host. We know sometimes when we do a CSF sample, for example, in an infant for acute encephalitis, it actually finds that there's DNA held within the monocytes, and that chromosomally integrated CMV that's hanging around in well infants even can give us a positive CMV PCR. Throughout life, it's really our natural killer cells that are responsible for clearing the initial CMV infection. And then we're in this relationship with CMV in which our T cell responses are responsible for just keeping a lid on virus replication throughout life. But we know in sick adults, for example, that, if they have a burn or a motor vehicle accident in blood, you get this uptick in both HSV and CMV as we take the brakes off and allow for viral replication. And so once humans have CMV, it establishes latency in myeloid cells, DNA in the bone marrow, and within monocytes. It's important to think about the transmission risk. And so it's transmitted via saliva, sexual contact, which is important in periconceptual infection of infants, placental transfer breastfeeding, which is relevant when we're talking about postnatal CMV acquisition in particularly premature and vulnerable infants, blood transfusion, in an area that it takes a lot of ID work and a lot of resources, is managing CMV positive donors to CMV negative recipients and the issue of CMV in post-cell transplantation. It's pretty hardy in the environment, not quite as hardy as things like RSV and measles, but can survive on surfaces for up to 24 hours and has a half-life of 2 to 6 hours. It's amazing the shedding that occurs. So infected newborns, about 3%, hospitalised children at any time, looking at wards, up to 7%, very high rates of shedding, up to 3/4 in some daycare settings. One of the other interesting things is actually shedding can be quite prolonged in some infants. So I think with a high viral load and perhaps some differences in immune system, in some infants, they've had continuing positive urine PCR out to 2 years. So very prolonged shedding in a subgroup. The seroprevalence varies greatly across the world, but generally in the Australian populations, that's thought to sit around 40% of women of childbearing age. A question that often comes up is, a CMV positive baby in the unit, what's the actual risk to the healthcare workers? And it's a way in which we suddenly find out who's pregnant within the unit is to have a case of CMV and everyone comes forward saying, oh, actually, it turns out I'm pregnant and what's my risk? I think a really good way of communicating that risk is actually the risk is not in the neonatal setting or in the healthcare setting. We know that annual seroconversion rates for healthcare workers are very low at 2 to 3%, and that's presumably because they practice hand hygiene and precautions around changing nappies in particular and secretions in a way that they don't practice at home. Daycare workers is a slightly higher rate, but actually our biggest risk for healthcare workers in terms of CMV seroconversion is actually going home to their toddler at home if they're seronegative. So if we look worldwide, we can see Australia down here sitting at around 40% seroprevalence. In developing countries, much higher related to living conditions, variable in the transmission within those settings, and obviously having higher rates of fertility and higher rates of children within the household, much higher seroprevalence rates. This is a busy slide, but I guess the important point here is to think about in a high seroprevalence versus a low seroprevalence setting, and we're a low seroprevalence setting where the majority of our cases are. And I think importantly, the prevalence of congenital CMV is directly proportional to the rates of maternal immunity, meaning higher rates of congenital CMV seen in populations with higher maternal seroprevalence. It's interesting to think about the impacts of changes in epidemiology, demographics. In Australia, for example, the age of first child is gradually increasing, but whether that actually translates to higher seroprevalence or lower seroprevalence given contact with children within our community. So modelling from the US in a low seroprevalence environment shows that 2/3 to 3/4 of all congenital CMV infections occur to newborns to mothers with non-primary CMV infection. So I think it's important to make that differentiation. So primary CMV infection is an IgG negative mum who's suddenly been exposed and had active CMV infection, so have low IgG avidity or no IgG, an IgM positive, and then developing increased avidity or IgG positive over time. So that's primary infection. Non-primary infection is CMV infection in a mum who has IgG, who's positive, who either through reinfection, through a positive contact with a high viral load, or alternatively through, as we were talking about, the immune system having a low level of dysfunction that actually they mount a CMV load. Or alternatively, the other thought is that actually while you've got good suppression, actually there's some genetic differences in CMV given it's a double-stranded DNA that actually you get reinfected with a completely different type of CMV, and therefore your immune system's not able to function. But if we jump across here and looking at the left-hand side in our low seroprevalence setting, we would say that 50,000 seropositive of that 100,000 with a 1% risk of congenital infection, 50% of seronegative, 400 newborns with congenital CMV infection. So I think the important point is that actually in our setting, the majority of newborns are actually going to be to mums who have non-primary infection. And so the challenge there is around antenatal processes and what you might be able to do to prevent that. Here you can see an overview of what's going to happen to that infants, that divide between around 90% being asymptomatic at infants, but having a 10% risk of sensorineural or hearing loss that in many will be progressive. And then this smaller group, the symptomatic infants, but that I feel that we see very infrequently in Australia, with a small rate of actually quite significant mortality, but a bigger group, around 2/3, that have permanent sequelae, including hearing loss in the majority, but quite significant motor and cognitive deficits. So this overlays all the studies of transmission risk, looking at gestational age. And so what we see is that severe fetal consequences are greatest in the periconception period, but actually the rate of transmission to the fetus is quite low. So there's a paradox there. Put in another way, if we look at this first trimester rate, the vertical transmission rate is about 1/3 for primary infection. But the risk of significant fetal insult is almost 20%, and a reasonable proportion of those will be symptomatic at birth. So I think a lot of our energy here is looking at these infants in the second and third trimester, where it's perhaps more readily identified. And in fact, the rates of fetal insult in this group are much lower. So really our focus of our work around prevention and identification really needs to be in this first trimester group, where the risks of fetal insult are going to be much greater. So zooming into Australia, the incidence of congenital CMV is thought to be at 3.85 per 100,000 live births. It's important to say that we don't have a national surveillance system, so we use the pediatric surveillance network that requires on-volunteer reporting. But establishment of a national CMV registry to identify cases has been challenging. We do know that there's different approaches and different mechanisms in terms of screening of newborns, either targeted or universal screening. Internationally, though, congenital CMV is the most common non-genetic cause of hearing loss, accounting for 20% of hearing loss at birth, but with the inclusion of progressive hearing loss, around 1/4 of all congenital hearing loss at 4 years of age. And is the most common infectious cause of neurodevelopmental delay. To go back a step and talk about the pathophysiology, what we see is that in CMV primary or reinfection or reactivation, there's CMV transmission. And where there's CMV transmission through uncontrolled viral replication, first in the mother and then significant viral replication in the infant, there's immune-mediated damage. So there's recruitment of T lymphocytes, plus there's probably an element of placental insufficiency, as well as fetal hypoxia in severe cases. And then there's this general idea that it's that CMV infection, particularly in the first trimester, that alters the normal blueprint of the developing brain, affecting neural stem cells, causing abnormal organisation and communication between brain areas. And in the most severe cases, that's what we're seeing on MRI. So talking about those 60% of women in Australia who are seronegative and therefore at risk of primary infection, I think it's interesting to think about what we're telling mums of first and second borns around their CMV risk. And so this is an Australian study, and you may know some of these colleagues from Sydney. It's interesting that 16% of women in the late 2018, 2017, just 16% have heard of CMV at baseline in pregnant women. 57% do not always wash their hands after changing a wet nappy. But importantly, knowledge improved with written information. This has been shown in a number of studies that actually providing information to families can help enhance that knowledge that CMV is spread by saliva or urine, and that actually we can interrupt this through simple hand washing measures. One of the fascinating things about this study is actually knowledge of CMV was inferior to knowledge about other much rarer conditions like toxoplasmosis and HIV, Down syndrome and spina bifida, although in most developed countries, congenital CMV has taken over from the impacts of Down syndrome, spina bifida, and in most areas, fetal alcohol spectrum disorder. So this is from the ACE perinatal infection guideline, which, as you'll be aware, was updated in 2022. We'll focus for a minute on the primary infection group. And in that group, there's a 1/3 risk of transmission overall, but identifying that risk of transmission is much higher as you progress through pregnancy into the later trimester. 10% of those children that are infected will have symptomatic congenital CMV, and we'll talk about what that means, of which 50% are at risk of sequelae, 50% hearing loss, 50% neurodevelopmental disability within that group. In the asymptomatic group, which is the other 90%, we know that the risk of sequelae is around 10%, the majority of that being sensorineural hearing loss at birth or progressive sensorineural hearing loss. In non-primary infection, it's very rare to have symptomatic disease at birth, but overall, similarly, a 10% risk of mostly sensorineural hearing loss. Thinking about what is symptomatic, that's highly variable between areas, and the literature is quite diverse around what we call as symptomatic. And of course, as our medical imaging has evolved from initially just doing cranial ultrasound to very high Tesla MRI, our definition of what symptomatic has really changed. And so those initial studies targeted treatment of the neonates who had CMV really from the end of the bed. They had growth restriction, petechiae, splenomegaly, hepatomegaly, the kind of presentation that all of us would be worried about a scorch infection such as CMV, that hepatitis and thrombocytopenia. And then, although microcephaly was initially defined as symptomatic disease, we've gone on to describe a range of MRI abnormalities. And I'll talk a little bit about how those same MRI abnormalities are predictive longer term of developmental outcome. So looking broadly at the outcomes in the symptomatic, up to 70% developing developmental delay, cognitive deficits, vision impairment. And so the mechanism is a mixed nerve involvement, but also chorioretinitis in a very small subgroup, up to 10% with seizures, and we saw that 4% mortality rate. I think the hearing loss is a really important component of this. And so the thought is that actually this is not just replication of virus that's been poorly mediated by the fetal immune response, immature fetal immune response, but actually we've got an immunological host response in the inner ear, particularly in the cochlea. And we know from fetal biopsy that actually the changes are quite diffuse, and there's a mix of inclusion bodies, which are the characteristic histology finding of CMV, but also quite active inflammation within the inner ear. And I think that explains part of the story, that while there's damage to the whole cochlea at birth, affecting both high and low frequencies, actually that it's that ongoing inflammation as well as potentially the ongoing replication of virus that leads to this delayed onsets of sensorineural hearing loss. Sometimes even in infants, 40% of infected infants will have a normal hearing screen at birth, but go on to develop hearing loss. And the median time for that onset of hearing loss for infants with infection, but normal-ish hearing at birth, is actually 44 months. So it's very delayed, and that underlies the recommendations around screening of quite intensive audiology right up to primary school, initially every 3 months in the CMV infected infant, to really kind of capture and have early intervention and improve hearing outcomes. The other thing is that, of course, even in those that have hearing loss identified at birth, they've got a positive newborn hearing screen and have been referred. Actually, that's not the end point of their hearing loss, and half of those infants will have further progression and deterioration of their hearing loss. So let's talk about diagnosis and prognosis, really moving on from the time of delivery and how we approach this. This is a busy, updated algorithm from the Australian Society of Infectious Diseases. And so it combines this laboratory investigation with either urine or salivary PCR, plus clinical examination, plus newborn screening. And it's really that positive PCR that drives the further investigation with ophthalmology. Head ultrasound and head MRI are complementary, but really I'd be advocating strongly for MRI because its role in prognosis and really excluding those infants and putting them in an asymptomatic category so that treatment's not required, or in fact ruling them in for treatment. And then divided into the following treatment groups: asymptomatic, isolated hearing loss, symptomatic, mildly or very symptomatic. One of the things that does come up is the performance of neonatal diagnostic testing. And so we know that amniocentesis with its associated risks actually has very high specificity. So while we might have a positive result and then we perform a urine PCR in the infant once they're delivered, we know a positive result is very good. Similarly, unlike many tests in microbiology, these are tests that have got really excellent sensitivity and specificity, including for urine, saliva, dried saliva spot, which has been used in some universal screening programs where you email back your saliva. But serology, as in many cases, is quite unreliable because actually the CMV infection has happened remotely. And then it's always a tricky thing to refer back to the Guthrie card because the sensitivity at best is around 60%. And so we can't rely on that to rule in or rule out CMV and sometimes need to return to the clinical picture. So when we're thinking about universal newborn screening and where it might fit, and as we'll get to in a minute, there's a real window for treatment here. We look at our Australian data, and this is from the Australian Enhanced Pediatric Surveillance Group. Congenital CMV was suspected in just 70% by a month of age. So you can see we're already pushing treatment back in Australia, and that actually there's quite significant rates of hearing loss in the symptomatic and asymptomatic cases, recognising an opportunity for treatment. So some clear predictors of poor prognosis. So at the end of the bed, microcephaly is associated with worse developmental outcomes. Chorioretinitis as a marker of neuroinflammation. Abnormal neurology, and the more abnormal your neurology is, the worse outcomes, and that's true at the time of examination at birth, but also on follow-up Bailey's, it's a predictor. And then MRI more recently has been prospectively validated as a predictor for developmental outcome and therefore informs our decisions around the aggressiveness of treatment. There was some excitement around CSF beta-2 microglobulin, which, as you may be aware, is a marker of leakiness of the blood-brain barrier and CNS inflammation. But what that adds on top of MRI brain is a bit unclear, knowing that some of that change is micro-inflammation at very focal areas of the brain, such as the temporal lobes and within the cochlear cells. And then sometimes we will perform a viral load for infants, and that's particularly important in those infants where we think there could be CMV resistance, or in the postnatal acquired CMV where we're trying to establish whether our treatment is working in very symptomatic infants. But unfortunately, viral load in blood, again, is not a good correlate for long-term outcomes. Alicon in 2016 developed and subsequently validated in 2020 for this comprehensive scale based on MRI findings. We can see it moves from single punctate periventricular lesions or ventricular striate vasculopathy through to extensive areas of periventricular calcification or brain atrophy, and particularly temporal lobe changes or multiple temporal lobe white matter changes are predictive of the neurodevelopmental outcome and longer term outcomes with follow-up out to 4 years of age. Just looking into the most recent prospective validation of that paper, and you can see here in the symptomatic infants a slight variability in those children that have very mild changes, and certainly the literature around isolated ventricular striate vasculopathy shows that it's not really clearly associated with outcomes, but really once you get to a neuroimaging score of 2 or 3 with significant changes, it's highly suggestive of moderate to severe disability with similar findings in those asymptomatic infants. And so very occasionally we have a completely asymptomatic infant who's passed their newborn screen, who on MRI has multiple changes, including calcifications, abnormalities of the cerebellum. And our prognostic outcome for them is mixed, but we're certainly concerned that they're likely to have mild to moderate disability. And so they're the babies that we would be targeting for discussing counselling around therapy. So probably the area that's changed a little bit over time is really focused on how we approach treatment and how we target treatment to those patients that most need it. In my mind, there's 4 groups. And so we've moved away from calling infants, tried to move away from calling them symptomatic or asymptomatic, and rather moving from CMV disease through to asymptomatic and CMV infection. And in the CMV disease group, dividing that into those that have clinical end of the bed evidence of CMV disease, and now adding in the MRI changes. And then there's a subgroup that's been tricky to further characterize. The potential for treatment is the isolated bilateral sensorineural hearing loss. Then there's the isolated unilateral sensorineural hearing loss, which is even more controversial in terms of who to treat. And then this asymptomatic group who have a normal MRI and have passed their newborn screening test. It's a good opportunity to think about where this evidence has come from. So in the 1980s, we knew that we had a drug that was active in vivo and in vitro against CMV. And there was a phase 2 study that looked at high doses of IV ganciclovir for 6 weeks. And high dose treatment was shown to stabilize or significantly improve hearing in 5 out of the 30 infected infants. And so that's where we started. We started with putting long lines in neonates and giving them IV ganciclovir for short courses of 6 weeks. And Kimberlin did the largest ever study at the time of IV ganciclovir for moderate to severe congenital infection, and found that the treated infants experienced worsening. 0% of the treated infants experienced worsening of hearing at 6 months, while 40% had worsening of hearing. By the late 1990s, valganciclovir had been developed, which is a prodrug of ganciclovir with good oral bioavailability. The PK study was able to show that you could match IV exposure by giving twice daily oral valganciclovir, but with some associated risks. And in 2010, a further RCT with just 23 neonates at great cost of over $50 million found that 6 weeks of IV ganciclovir followed by oral valganciclovir out to 1 year of age really stabilized hearing, and so longer was better, but what to do with that practically. And then in 2015, we had further evidence that really 6 months of valganciclovir therapy compared to 6 weeks of therapy was better in terms of neurodevelopmental outcome based on Bailey studies. Looking specifically at this study, what they found was that there was no significant difference in best ear hearing at 6 months between the 6-week or the 6-month group. However, hearing in one or both ears was more likely to improve or remain normal at 12 months of age in the group that received 6 months. Notably, this benefit in sustained improvement in hearing was seen right out to the 2 years of age. And the group that received 6 months of treatment actually had better neurodevelopmental scores at 2 years on Bayley's. That was particularly in the language component receptive communication scale, so presumably influenced by some degree to the improvements in hearing. So when I'm very cautious around promising to families that with treatment we're going to completely modify the developmental outcomes, particularly in those infants with very abnormal CMV affected brains. They had similar treatment benefits in terms of hearing, regardless of CNS involvement at baseline, but that was specifically in terms of hearing, and similar results for those premature infants and for those who started treatment very early versus early. All of these infants received treatment overall pretty early in their course after diagnosis because of the symptomatic nature of them. And you can see kind of the extent of disease was quite high here, in which 80% of those receiving 6 months had thrombocytopenia. There was almost 3/4 with CNS involvement. So the challenge we have and the controversy we have is treatment of isolated sensorineural hearing loss. And in 2017, we had 2 international consensus guidelines, presumably with similar experts across both panels. One of which, the American, saying antiviral therapy is not recommended for isolated sensorineural hearing loss. And then the European saying that actually the majority of this meeting would include sensorineural hearing loss at birth in their indications for treatment. We've subsequently discovered huge variations across the US and actually in Australia as well. And so 60% of pediatric ID physicians in North America disclose treating isolated sensorineural hearing loss with 6 months of valganciclovir. Finally, though, we have a bit more data around this. And so this is the CONCERT study, which was published in 2020, I think, in which it was a non-randomized study of infants aged less than 30 weeks with sensorineural hearing loss and congenital CMV who'd failed 3 consecutive newborn hearing screen. The mean age of treatment was a bit later than what we'd like to see, so it was 61 days, but you could see practically even in Australia, you know, the challenges of identifying infants, very quickly getting them through to ongoing screening, blood spot, diagnosis, counselling and treatment. 35% had mild hearing loss at baseline, but mean best ear hearing deteriorated by 13 decibels in the control group. But actually what you saw is improvement or stabilisation in the treatment group, and just 2.5% in the treatment group deteriorated. Importantly, for those group that had bilateral hearing loss, they frequently improved and none of them deteriorated. Importantly, in this study as well, neutropenia occurred in 1/3, which is anecdotally what we see in our practice as well. So looking into the groups, you can see here the percentage improvement, around 15% in the severe hearing loss, 70% in the moderate hearing loss, and 92% improvement in the mild hearing loss. And so this is important in informing our families when you're going into treatment around what we're kind of expecting, that actually for severe hearing loss, we might stabilise hearing, but we're not over-promising complete recovery of hearing. And then Kimberlin, again, very recently published this study of treatment beyond 1 month of age, which is probably an unfair title because most of those infants started, you know, the youngest was 3 months of age who started treatment for sensorineural hearing loss. And really this was a practical study thinking about at some stage when you identify an infant within the first 2 weeks of life, is it within the first 2 years of life, is it worthwhile if they have confirmed congenital CMV at that stage, starting them in a very delayed sense on treatment? And this was an RCT of 6 weeks of oral valganciclovir 35 infants. The mean age of enrolment was actually towards 18 months of age. And while the viral loads in saliva and urine dramatically increased in the treatment group, this didn't actually modify hearing outcomes. So this highlights that there's a narrow window for therapy, and probably overall the earlier is better. And then the further piece of information that's come from these studies is actually for isolated sensorineural hearing loss. It seems that actually 6 weeks of valganciclovir versus 6 months is as good. So while we don't have evidence currently around treating mildly symptomatic congenital infection and actually very unclear data around unilateral sensorineural hearing loss, it's important to think about benefits and risks. So on one hand, we have stabilization or improvement in bilateral sensorineural hearing loss if started early, and improvement overall in CMV infected infants, particularly around their language and receptive communication. On the other side is the expense, the monitoring, which is fortnightly full blood counts, then monthly through the rest of treatment out to 6 months. The 1/3 risk of neutropenia, and we've certainly seen valganciclovir-induced neutropenic sepsis related to treatment. We know that in a small group of kids, they'll develop hepatotoxicity. You can get thrombocytopenia related to the treatment independent of the CMV risk. And we know in the lab, at least, that there's gonadotoxicity with potential implications for fertility in animal models, at least. And then again, an overall unquantified risk of carcinogenicity. So this is a pretty complicated conversation to have with families and quite nuanced. The first time I had this conversation with a family around whether we'd start treatment was, of course, in a child with isolated sensorineural hearing loss before these RCTs. Family, both lawyers, one a professor of law. So I was very careful to go through all of these risks and make sure that we were having a balanced conversation about what the data really tells us. So where have we landed? So this is the 2026 update, and based on that paper below by Kimberlin summarising his life's work, and as well as other prospective studies that have sort of validated this. In CMV disease, in which you've got multi-organ disease or significant persisting manifestations of disease, or a very abnormal MRI, really we should be giving valganciclovir as early as possible for 6 months with appropriate monitoring and after counselling. For isolated sensorineural hearing loss, well, on balance, giving 6 weeks instead of 6 months. We've got reasonable evidence to support that, and particularly in bilateral sensorineural hearing loss. Again, there's clearly a window to start this, and the earlier the better. Mildly symptomatic congenital CMV on a case-by-case basis, and there's no evidence and is not recommended outside of research to treat those children who are CMV infected but asymptomatic at birth. So what else is there? We've been sort of using valganciclovir since the 2000s now. There must be something else on the horizon. And so in the transplant population, there's a real interest in specific cytotoxic T lymphocytes. So these are lymphocytes that are trained towards a virus, in this case, CMV. And so there is an active RCT that's recruiting in Los Angeles that's looking at how we might be able to give cytotoxic lymphocytes alongside antiviral treatment. Initially, they're looking at safety, and then they'll follow on to randomized antiviral therapy with or without CTLs. I have some anxiety around this because CTLVs are highly effective, and it's not quite CAR T cell therapy, which some of you may be familiar with. But what we're doing here is really using a virus to get using a lymphocyte to get in and eliminate the virus very aggressively. And you could hypothesize that actually what you'll see is, for those heavily infected infants at birth, added neuroinflammation related to that. And I think that's where we're stuck, is this balance of the infection, but inflammation, and how we weight those things in terms of what's causing the damage. The other emerging therapy is letermovir, which is first-in-class inhibitor of the viral DNA terminase complex. It's thought that it's likely more effective across a broad range of CMV DNA types. It was first approved in 2017 with really good data in this transplant population and oncology immunosuppressed population to show that this is a good agent for prophylaxis and potentially for treatment. And so the next part is an RCT that's actively recruiting to think about whether oral atemavirine over valganciclovir might have better outcomes. But it'd be nice if we didn't need to have any of these conversations. And so I think there's plenty of work to do in Australia, and it seems to be the case in many other countries about how we prevent CMV. For any people who have worked in the UK, Hermione Lyle, who's an infectious diseases physician based out of London, has done a lot of work thinking about prevention. And so there's a number of great resources for the UK, and they've really focused on upping their maternal education to try and prevent maternal primary infection. So there's a couple of different approaches to prevention. The first is how we might integrate universal maternal screening and providing education to those parents, both IgG positive and negative, and then maternal treatment of infection to prevent fetal transmission. Immunisation is exciting, but to be honest, underwhelming in this space so far. And then universal newborn screening and access to early treatment, which requires significant policy and systems in place to make sure this could happen. For some of you that work in maternal fetal medicine, you'll probably be aware of this RCT that was published in The Lancet in 2020. And what they had is 91st trimester and periconceptual CMV infections, so occurring right around the kind of time of conception. And of course, knowing that although the rate of transmission is low, they're the infants that are going to be at most high risk of symptomatic disease and neurodevelopmental disability. That was the group that was chosen to target. They were given placebo or high dose valacyclovir from diagnosis all the way through to amniocentesis at 21 to 22 weeks of gestation. What they saw is that the vertical transmission rate was reduced by 71%. An observational study conducted in Italy demonstrated that not only does the valacyclovir treatment started early reduce the vertical transmission rate, but was also associated with reduction in termination of pregnancy. And actually, for the first time, they were able to follow those infants through and show that you reduced symptomatic congenital CMV at birth. Unfortunately, we don't have longer data to show what the developmental outcomes are in those infants. And that will be complicated a little bit by the fact that you would need to protocolize treatment in those infants or adjust for that effect, in that some of those infants with congenital CMV will have also received treatment that's not prevented transmission. They've got infection and they may be offered treatment. The other area that we don't have, recognising that this was purely for primary infection, is the role of valacyclovir in preventing congenital CMV in the setting of non-primary maternal infection. And part of that is it's a challenging diagnosis to make. We have a mum who's IgG positive on screening. For most mums, reactivation or new infection will be asymptomatic. And so, it would be down to testing mums on a monthly basis if there was evidence that treatment could prevent transmission. So this is one example of how maternal serology screening could work. And so what you would do is perform serology in the mother, repeat it every 4 weeks until 24 weeks. If it's negative, you're done. And then in the group who's got evidence of probable primary infection, consider valacyclovir, amniocentesis. Either you're infected or not infected, and in those infected infants, you continue on potentially with valacyclovir, thinking that there may be a role in reducing their CMV replication in the fetus, knowing that valacyclovir does get transmitted across the placenta and enhance delivery. So there's a very patchy approach, and certainly we know in those mothers receiving private obstetric care, the rates of testing for CMV are much higher. No RCT has compared the impact of maternal screening versus routine management of the prevention of complications in newborn. When you look at this debate for maternal screening, is that we know CMV is a very common cause of disability in newborns and the most important cause of non-genetic hearing loss. In the IgG negative mums, you could argue that that provides for targeted education in that higher risk group. And in the IgM positive group, you may be able to have potential access to timely treatment that may lower the risk of fetal maternal transmission. But then against, in our setting, most congenital CMV occurs in seropositive mums. Our education programs have clearly not been optimised at a national level, and we're not talking to mums about mums and families about CMV enough. There's also this important factor of the high rates of false positive IgM, in which the specificity is only 50%. So in that group, you can imagine the added concern about there being primary CMV infection, only to find out that that's been a false positive. There's also a very short window for intervention. The evidence shows probably, depending on where you're screening, you probably have 5 weeks to work your way through that, establish that this is primary CMV infection, and initiate treatment. This would be expensive, particularly once you start included the added costs of enhanced monitoring and screening. And then the acceptability to families has not been explored. We know that universal screening in neonates has good acceptability around for families, but not this kind of approach of enhanced antenatal surveillance. So what's on the horizon in terms of immunisation? The pursuit of a vaccine against human cytomegalovirus has been ongoing for more than 50 years. There's been several candidate vaccines along the way focused on preventing CMV infection during pregnancy, and those are at various stages of clinical trial. There's a bit of a tricky aspect to this, in which antibody development prevents acquisition and acquisition and spread of CMV by seronegative individuals, but actually it's generating a T cell response that we need, and a sustained T cell response to suppress reactivation by those who are seropositive. You can see here the current vaccine candidates, and there's a bit of a mix. So up the top, an adjuvanted GB protein component vaccine, another one, BB1501, both in phase 1. And then an adjuvanted killed CMV virus in phase 2. Again, an adjuvanted GB protein component. And the one that was most exciting, which is the 1647 Moderna vaccine, which had actually just recently entered phase 3 trial, a combination of the GB plus an mRNA component. Unfortunately, the Victory CMV trial, which was running internationally, closed in November. It seems to be coming out of a signal of futility. So disappointing at this stage, but we'll continue to monitor this space. To summarise now, I think there's a number of remaining questions. So the role of universal maternal CMV screening, and I think that will be an ongoing question. And I think as we've got such a variable approach to universal maternal CMV screening, we're likely to see prospective data before randomised control data. I don't think we've really found the optimal agent for preventing maternal infection and fetal transmission, but I'm hopeful that there's a vaccine candidate on the horizon coming out of the mRNA rapid development pipeline. And then the cost effectiveness of universal neonatal screening is a question I think we need to revisit now that we have good evidence to show that in sensorineural hearing loss and isolated sensorineural hearing loss, that we've got an opportunity here for early intervention, and that's time critical. And furthermore, we need to be thinking about identifying those asymptomatic infants that are not known to be infected, and recognising the significant impacts of MRI changes as a predictor of long-term neurodevelopmental outcome, and really targeting those groups with treatment. And then I am excited about particularly letermovir, in the idea that that may be a very practical solution and actually may achieve more rapid viral suppression and hopefully settle some of the secondary inflammatory consequences. I think there is going to be increasing interest in this space about how we use not only antivirals, but adjunctive anti-inflammatory agents and potentially biologics in infants to switch off that inflammation that's going on within the inner ear cell, in addition to just the CMV infection. And then, unfortunately, at this stage, we continue to counsel patients, families around the unknown long-term effects of ganciclovir and valganciclovir, and I think we need to understand that more. The research priorities in my mind are improved primary prevention approaches, evaluating the cost effectiveness of universal newborn screening, and identification of a biomarker ultimately to identify those infants that are at the greatest risk of complications down the track, and really targeting treatment. Touching finally on some of the final points and the broader points, particularly for trainees, I think we do need to have a high index of suspicion and choose the correct diagnostic test, either urine PCR, which is available, or saliva PCR at least an hour after breastfeeding, due to the risk of false positive related to CMV being excreted in the breast milk. We need to confidently evaluate these infected infants and recognise, particularly for symptomatic infants, there needs to be early access to both cranial ultrasound and then MRI brain, but really MRI brain for all. And then multidisciplinary management of infected infants. We have an infectious disease centre in each state with growing experience in treatment, but hopefully I've highlighted some of the nuances around counselling. And then I didn't go into this, but for some of you providing follow-up to congenital CMV-affected infants, really they need an eye review until 5 years of age because of an ongoing risk of chorioretinitis. Aggressive surveillance of hearing because of that delayed sensorineural hearing loss risk. And then developmental screening, and we'd recommend a Bailey's at some stage to predict and provide targeted intervention. A number of references, and I'll stop there for questions.
Wow, Coen, that was fantastic overview, and indeed sort of an update, certainly for me, about what is going on in the world of CMV. That was hugely appreciated. And you took us through the epidemiology, which is not as straightforward as in, other sort of diseases. And part of it has to do with the transmission and the transmission numbers. And then rightfully, you used the word risk quite a lot, and that risk in the assessments and the balance is very strongly associated with what comes later, how to apply screening programs. We're definitely going to have some questions about that. You took us to the treatment options, not only the evolution of the treatments and then the trials, and everybody must have taken a picture of that. Okay, this is the final recommendation slide, because that was very, very helpful. Earlier and longer is better. And then I took that, I thought it was really important you highlighted at the end that counseling for treatment is actually not that simple. That should be done by an expert. It's not like a simple treatment anybody can just start. You really need to know what you're talking about, what are the benefits and what are the risks. And then you highlighted everything again about prevention, and we come to that as well. So wonderful overview. There's some questions in the box. I'll start with that. Dames has a question for you about, universal screening. You highlighted a couple of times. Where are we in Australia? Are there meetings going on, or what's happening?
It's a great question, and unfortunately, I'm not across the policy space. It goes without saying that that's expensive, like all things. The best data we have is from, Pam's online. You've just popped up, Pam. So we have one of Australia's experts in the room, actual experts, which is great. But just to say that, the best evidence came from Queensland. in which they were able to implement this. But what it really depends on is the systems being there to funnel those infants with a positive screen result quickly through to get confirmatory testing, and then through to diagnostic workup and assessment and MRI. And then you need somebody to do that counselling around treatment. The MCRI group based in Victoria have done the further bit of work here, which is going back to a huge birth cohort and looking at their Guthrie cards and saying, you know, what's the actual problem here? What are we missing here? And modelling that to look at what a program might look like based just on the Guthrie card.
Pamela, you want to comment on this? It's a great platform here. Thanks for joining us.
Thanks. First, I just posted a comment, and it's an excellent talk, Coen. I also learned a few things here in this, so thank you very much. I just wanted to maybe circle back on the question that's asked about what's happening with testing. Nothing. That we're not doing antenatal testing or universal. There's no appetite for it in the policy space at the moment. There's a lot of background, but there's lots of groups across Australia who are interested in this. Some of us are interested in the information space. You presented one of our studies there with the knowledge. It's very poor knowledge, and many of you in the audience who might have met up with families with congenital CMV babies, the first thing the parents say is, why do we not know about congenital CMV? It's so common. We only know about it when we have an affected baby. We have not been able to change that, despite all the we're informed. You know, maybe I'm preaching to converted in this group who are interested and learn, but it's still very poorly understood out there. So there are spaces we're doing some work in that, but that's no universal screening. So what are we trying to do? We're trying to do what about targeted screening? So you alluded to that, the low-hanging fruit. We don't have universal. So that was the mothers I was talking about, universal screening. Actually, I've got to say something else. I don't know what your experience has been, but our antenatal groups, those who do those who identify or get referred mothers who are known primary infections in the first trimester, those women will get the valaciclovir for the first trimester, so in primary infection. We're not seeing any more congenital CMV kids from that space, and it's really dropped off for the counselling. So it may be universal. I don't know what it's like in Singapore, but that's the first thing. So it's really effective, that valaciclovir treatment. So I'll leave the maternal space. I'm talking too much. I'll be very quick. So basically, the postnatal space, no universal testing for babies either. So, but we know that it's 1% of all pregnancies will be congenital CMV, of which, as you alluded to, about 10% will have symptoms. But there is the low-hanging fruit strategy, which you alluded to. You target test. So we're doing a little bit of work in if you fail your newborn hearing, we'll test you, and it's about a 5 to 10% pickup rate only. There's a lot more out there of kids who are missing the testing, and you may say, so what? Most of them get asymptomatic, but the problem is 10% of those will have late onset hearing loss. So that kind of answers some of the questions. Sorry, I took over the last 5 minutes.
I agree, Pam, and I think it would be nice to see improvement of dried blood spot. You know, we're already taking dried blood spot from infants. We'd like to see that work, but we're in a developed nation with lots of resources. I think when you look at Wilson and Jugner's principle for mass screening for a disease, it ticks off most of these areas. And so I think we should be looking at how we do this on a national level.
Dollar signs, that's the problem.
Yeah,
and it's not, sorry to say, but it's not sexy enough for some of the policymakers.
Yeah.
Coen, there's a question about that newborn screening, particularly targeted to the preterm infants, where Pranav asked this, where we see a baby, he's okay, and then he gets usually a lung disease, which is maybe a bit more than expected. And we then want to know, is this a postnatally acquired CMV versus a congenital? How good is the newborn screening test in that scenario?
Yeah, so we know at best it's got 70%. 70% sensitivity. So that's a really hard situation. I think the first thing I'd say is that postnatal CMV also has been underappreciated, particularly in prem infants the havoc and significant impacts that has on lung development and brain development. And so I think we need to be thinking in our units about how we're approaching breast milk transmission, how we're managing this issue. But I think in that setting, the first thing we'd go back to is maternal serology and establish whether there was any evidence of infection. And most centres will keep maternal serology for a long period. And then sometimes we can go back to blood and do PCR, which is always the best test in this setting to work out, was there a positive, a point where this baby in plasma went from negative to positive. And that's our best estimate. But there is some cases where it's not clear. And so we would often err on the side of caution in an infant that's very symptomatic, particularly if they've got evolving MRI changes, to treat them as a severe congenital CMV.
Yeah. And in those cases, there's a question here from Matt, and I'm assuming that's what he's asking. Is it sensible to test other materials like express breast milk?
I feel like we're coming back to the GBS debate and culture of breast milk for GBS here. But I think, it's what you do about that information. And I think once a baby is infected, and particularly if on their treatment, the ongoing risk of transmission from breast milk is low, and probably that risk is much less than the risk of excluding breast milk altogether. The other option, of course, is where you're concerned about a high viral load in a mum, is using short-term heat inactivation. 5 seconds at 62 degrees maintains the healthy aspects of the breast milk without the disadvantages of CMV transmission. But we wouldn't routinely recommend in CMV disease just abandoning breastfeeding or routinely testing.
Well, there's another question here from somebody, which I really like. It's about education. Why didn't you tell us that there was this disease? How can we educate people? What can we do? And I guess you have to start in high school, isn't it? Or actually maybe in primary school before you get to childbearing age. And I know back in the days we had chickenpox parties. So you brought your child there, so you got chickenpox early so you didn't get that sick. Can we have CMV parties?
CMV transmission. I think that will, if we convert the rate to seropositive in the population, then you're sort of going part of the way. But then, of course, there's this ongoing risk of reactivation of CMV. And it's interesting to think about again what our demographics do. If you have CMV early in life, and then actually at 40 you have your first baby, what does that mean in terms of your immune system and your risk of reactivation throughout the pregnancy and transmission to the fetus? But I think you're right. Early education. I know, in COVID, we were able to demonstrate that actually the best value in terms of education for hand hygiene was teaching kids to sing songs and wash their hands. And that actually had effect on whole households and their COVID risk transmission. So you're right, we should start with the kids.
Some solutions are very simple. Look, it's 2:03. Thank you so much. This was a wonderful presentation, and thank you all for attending. Pamela for commenting. We'll be back next week. I think I'm going to talk about is there a way to prevent IVH? Hope to see you all next week. Thank you again. Thanks, Coen.
Thank you very much.